So thank you, Annika. Thank you, Christine, for inviting me, and Health Education England and the UK Pharmacogenetics and Stratified Medicine Consortium. So I'm going to talk a little bit about pharmacogenomics in the 100,000 Genomes project, and also show you a little bit about how we're using this to stratify patient care. I'll also touch on areas where actually we need to consider as a community that it may not simply be traditional small molecules that are the drugs that we often prescribe that will be used in the future, and to also give you the opportunity to see how we're thinking of the new mission for the next 5 years and get your input into that. So this is a summary of the 100,000 Genomes project. Probably nobody in this room needs a summary of the 100,000 Genomes project, because you're probably here because you've been connected to it. But just in case, that was focused on rare disease and cancer and infection, and it's now reached about 97,000 participants, either patients or family members. We hold 22 petabytes of data, and that required the infrastructure that Sue showed, and I won't dwell on that, except this gives me an opportunity because at 2:40 a.m. on the 2nd of December, we sequenced the 100,000th genome to thank fantastic colleagues across the National Health Service. We estimate now that approximately 5,000 people worked on this project from the frontline health system, and now over 3,000 researchers from across the world in 24 countries who volunteered to help us make sense of this information and drive up its value for clinical use. Now, we have slightly different numbers to Sue's because we've also got in our data center the NHR bioresource. So we have 120,000 samples, which break, as you see, between cancer and rare disease. And today we have over 109,000 whole genomes. So this is one of the largest sets of whole genomes in the world, and it's the largest in direct conjunction with healthcare. We've returned over 76,000 genomic analyses to the National Health Service in rare disease and cancer, and they're working through those. It's fair to say that's an enormous undertaking, and this has provided some challenges, but as usual, our colleagues in the NHS and across the system are rising to that challenge and bringing new diagnoses to people. So today, available for the researchers who want to use it, are 91,000 genomes on 94,000 people. We'll release more next month. And about 1,800 of the researchers who we call the Genomics England Clinical Interpretation Partnership, because what we want to send is a signal to those researchers that they're not just there to do research, though their research is very important. They are there to change the impact of this for patients. And that connection is something that's important to make in a direct healthcare transformation program. To speak to the question about industry, we have over 100 companies in our discovery forum, and 5 or 6 of them are working with us very closely on specific projects. I can tell you that just like the academic researchers, industry have helped us to make new diagnoses for patients, so they found things that we had not found, and that has allowed us to return diagnoses to patients. Specifically, what are they doing in there? They're looking at data to try and either identify new therapeutic targets for disease that could bring benefit to patients, to identify how medicines might be used better, and also to see whether they could identify participants from our program that could participate in clinical trials. And that's done with the full support of our 35-strong participant panel. In fact, they want to be recalled for research, and recently when someone suggested that they mightn't be, they were somewhat irritable about that. So people facing rare inherited diseases and cancer, these life-changing events for families and people with cancer, mean that people view data access differently in relation to industry from other groups. We've also tested it with the public and patients, and our recent work with Ipsos Mori shows strong support, providing there's a fair return on the provision of data for industry to work on that, as long as it's connected to a healthcare gain, and that's absolutely fundamental in our consent. So in rare disease, we're achieving potential actionable finding in 1 in 4, 1 in 5. This varies a bit depending on where we are in the program, and we focus the program in rare disease on unmet need. So this is about providing opportunities for people who've not achieved a diagnosis through usual care. In cancer, this is a major change in our molecular stratification of cancer, and to my surprise, but this may change, about half of the patients have the potential to receive an opportunity to participate in a trial or perhaps receive a medicine through the health system. So that's a big potential change. I wanted to just emphasize to you that not all the solutions that offer therapies are drugs, but nonetheless the genome can stratify our choice of those, just so that we don't all think we're here just to talk about medicines. So I wanted to share with you a few cases, update you on one we've shown before. So there was a 4-month-old in 2015 who entered the program. He'd had fluctuating neurology, repeated infections, and no cause had been found, and he died without a diagnosis at 4 months. In fact, he was born, went straight to the neonatal intensive care unit and died there 4 months later. Mum and Dad asked us to enroll this child in the program, and through the genomic medicine centres we did that. In fact, we have several deceased children in the program because Mum and Dad want answers for future reproductive health. Should they have other children, or is the risk very high of another child like this? And then the mum became unexpectedly pregnant. She said, look, I don't want to know. Don't tell me anything. I'm keeping this baby, and I just don't want to know. But at month 8, she did get anxious and asked for the results. And we found a mutation in a gene that transports in the protein form vitamin B12 inside cells. And this explains the fluctuating neurology, and it explains the immune deficiencies in the child. And the brother was born in February of 2015 and was tested within 1 week in the NHS. And because they had this knowledge, they could do this. Sadly, he was also affected. But the difference was in the report that we returned, and this is to emphasize that not all the solutions are drugs, and sometimes they're as simple as vitamins. There were case reports that said high-dose vitamin B12 can manage to get inside cells if you use it. But this was based on case reports. So this child has had high-dose vitamin B12 since then, and we followed up on that child very recently, and that child's alive, well, has mild intellectual disability, but can walk, talk, interact with you in a normal manner, and has never been to ITU. So this is not going to happen for everybody here. People in this audience know that well. But what if for a few we could change this course? And if I share with you that the total societal cost of a child with intellectual disability, that's all the care that we provide in the NHS, all the things we do in primary care, all the things we do in social care of that, and the familial cost is about 150,000 sterling a year, then you can see that if we can change the course for this, we can make this an affordable option for the NHS. So I'll share with you one other case, which again is not a drug treatment, but it does emphasize that the therapies are there for some cases. This is a young boy who had anemia, constipation, short stature, and he had intellectual disability. And because of the intellectual disability, when we analysed the genome, we looked specifically for intellectual disability genes. Now, this child had a really terrible diagnosis of diamond black family anemia, which often ends in cancer, usually has a very limited lifespan, and the parents have been given this as a clinical diagnosis based on the anemia and some other features. However, when we deployed the intellectual disability panel focused on looking at the cause of the developmental delay, that child had a clearly pathogenic mutation that's known in the thyroid hormone receptor. And in some children, giving higher than normal doses of thyroid hormone can address the anemia, the short stature, and the constipation. Sadly, we won't be able to fix the developmental delay because that's already fixed, but use an option for treatment. So I wanted to use those cases just to emphasize that not all of our solutions are drug-based. However, I do want to give you one, this is not my perspective or not my summary, this is a mum speaking from the program, and I thought I'd let you read what she had to say, which is you can see the film of this lady speaking about this on our website. So her child is 5 years old, and we've got a diagnosis for her of something called GAMT deficiency, and that's really simply treatable. With simple dietary components, you and I have probably eaten all of these things in the last 24 hours in our diet. However, for this child, she needed higher amounts of this, so she needed to have supplements. And the mum of this child thought she had a degenerative neurological disorder, was destined for a wheelchair, and had uncontrollable epilepsy. In the time you'll spend here today, she'd have had multiple seizures. So the child became increasingly locked in, so really couldn't interact at all, and would have huge tantrums because they couldn't really interact with their environment. And simply that mum's joy at receiving the opportunity to receive a dietary change, again not a drug, of creatine, ornithine and arginine, means that child's a new child now, not yet entirely normal, but we don't yet know how this will end. But the child can now interact and is learning new skills every day and is epilepsy-free. So this is not going to happen for everybody with a rare disease. I need to be honest with you. But if we can achieve that, even for a few, at the cost we spend on managing and supporting families with these diseases, that is a big transformation. But I want to also set in your minds the possibility of a different future. If we are going to, as a society, make a major endeavour to identify the causes of these rare diseases, and we sit at a moment, as you do today, where therapeutic innovation that we couldn't have imagined in rare diseases is beginning to occur, then it is, I submit to you, and it's your decision whether you agree to accept this, that we should have a joint mission to make sure that if people are coming out of these programs with a diagnosis, that we use every bit of energy we can to provide them with the therapies that could give them a chance of a better life. Maybe not normal, but a better life. And that is not necessarily, in case, Sue, you're getting a bit worried, that I'm consigning to huge medicine costs. But what we do, I think, have a pivot point here is because we are the first nation to adopt whole genome sequencing at scale, is to ask ourselves, if we're going to give out diagnoses, but you don't have access to medicines that exist, how are we going to manage that? And there is an opportunity for us to take a different approach to this, I believe, now. So, for example, there are combination therapies that are reducing hospitalization in cystic fibrosis, and these are stratified based on the mutation type you have, and so some therapies work better with different mutations. So this is absolutely what we want to achieve, a targeted therapy given to the right person first time, hopefully with minimized side effects. There now are therapies that we wouldn't have imagined even 2 or 3 years ago that can actually mask a part of the DNA that's prematurely truncates a protein and makes it not work. And one of those drugs, Munir, would you believe, is triamcinolone, an old potassium-sparing diuretic which we've had since he and I were in short trousers. That's a long time ago. And its only side effect is it causes blue urine and sometimes the occasional high potassium. But actually, it can sit in the cystic fibrosis gene on top of the truncated protein and cover it. So when it's read through, the read-through from the RNA doesn't see that there's an instruction to stop. So it reads it through as if it's normal. Now, that's still a distance away from the clinic, but these sort of therapies are beginning to become feasible. There are RNA therapies. For example, there's RNA therapies now targeting Huntington's disease, which we might not have imagined before, which can reduce inside the brain the Huntington's mutated protein by about 20%. What if we can do this and really get this? Huntington's is often a disorder discovered late in life and after someone has already had their own children, so it's passed on. And it gets worse in each succeeding generation. What if we could attenuate that? Maybe not stop it, but attenuate it and reduce disability or the inevitable downward spiral that goes with that. Other gene therapies are becoming feasible. The possibility of gene editing. Now, these are all expensive, but I believe that using pharmacogenomics, and I suspect others here do, because you wouldn't be sitting here otherwise, can help us select the patients to get the most benefit. So the moment is here for us in the next 5 years to ask the question, if we're going to try and get rare disease diagnosis for as many of our community as desire it, then we better look as a group at how we give an outlet for that that involves access to new therapies in an affordable manner for the health system, not at huge cost, tailored to the individuals where it will work the best, and create a UK platform from the next phase of our programme for trials, which means that for the first time, a nation on this planet can deliver a comprehensive rare disease care service, linking the fact that we have the opportunity to study things here at scale because we can identify from a national genomic knowledge base the patients who might benefit, and then present that opportunity to co-develop those therapies and link that to a much reduced price for that therapy in the NHS, targeted to the people who will benefit the most. Not here today, and it may sound like science fiction to you, but I think a good part of our mission for the next 5 years should be to make that a reality. So I just wanted to share with you a little bit about how we've been using this technology in cancer. And you can see here all the different cancer patients that have been enrolled in the study. So the NHS has enrolled 18,500 patients in the cancer program. And most of those patients involved re-engineering molecular pathology across the NHS. So 400 molecular pathology pathways for fresh tissue supply. And I'm not going to show you a picture of fresh tissue versus formalin-fixed tissue, but suffice it to say, formalin-fixed tissue gives a poor product, fresh tissue gives the optimal product, and that's what I'm going to show you data from. Now, I mentioned to you earlier that if we just look at 136 genes where we know from prior evidence that there's a potential opportunity to choose a therapy or target a therapy, then we can see in the first 5,700 patients a possible actionability in up to 50% of those patients. Now, in the light blue, what you're seeing is small single letter changes that are identifying potentially actionable genes where there is some evidence, but there's not yet the evidence to bring it live. The rest are definitively evidence-based variants that we're seeing. Now, let's imagine that this doesn't quite hold true, but this reduces. But even if it became 30%, if 1/3 of cancer patients could use their genome to select therapy, we need to think about how we manage that, and of course that's what's uppermost in Sue and my mind. And I just wanted to share with you a couple of things about this. So on our report, you can see that there is, at the top there, a BRCA2 mutation in this patient. And now in the next period, we'll be bringing this live, that we can be able to return pharmacogenomic variants that highlight the toxicity of cancer chemotherapy that you might have. So this double-edged thing of helping you to choose therapy for a trial. Now, we have someone with a BRCA2 mutation in the program who entered the Olympia trial with olaparib because of the program. This person didn't have a known risk profile for hereditary breast cancer, no family history, not from an at-risk community. Nonetheless, she had a BRCA2 mutation in her tumor, which was also present in the DNA she'd inherit from her mum and dad. And as a result, she entered a trial. What if she'd been randomized, though, or received usual care with 5-fluorouracil or capecitabine? This second phase gives us the ability to avoid harm. And the harm from those drugs can be major organ failure, skin loss, and various other things. And you can see here how we report the different variants. Now, this will eventually be fully live in the health system, and we will use this as a pilot test case in cancer. But you can see now how we're trying to use that data to think about this in two ways. How can we choose the therapy in the front, and how can we avoid harm in giving that therapy? So let me give you a case where we've been able to help choose therapy. So this is a 42-year-old man who did a past history of HIV and hepatitis B. He presented with weight loss and jaundice, and he had this very large area of cancer in his liver, which when biopsied was colon cancer. Now that biopsy was sent for usual care molecular testing, and then he received usual care chemotherapy according to the molecular testing, and this got larger, and he started to get pain and became even more jaundiced. So he said, is there anything else that can be done? And he was entered in the 100,000 Genomes project, and we found that he had a mutation which he'd inherited or developed at conception that meant he had something called Lynch syndrome, a hereditary predisposition to colorectal cancer, which some people carry. Now, as a result of that, what that means is he has a high tumor mutational burden, so he's got lots of mutations, and he can now enter an immunotherapy trial, which he has done. So this is the opportunity that this opens up, and I'm showing you an individual case because it's really to bring live the notion that you can bring this to individuals. There's several examples where people have entered trials. The other thing we send in our report is we link the patient to the trials. So on the right-hand side of the report, it has hyperlinks to all the trials on clinicaltrials.gov. Further thing that we're doing to try and maximize the opportunity, and we will try and do more of this in the next phase, is to take a situation where we take as many of the colorectal cancer patients we have, 229, at that point we did this analysis, and then we map them across England. So in blue, what you're seeing here are all the patients in our program that might become eligible for this advanced colorectal cancer trial, and in red, you're seeing the patients we can identify who are eligible today. So this gives a two-way approach. The first part is our individual report for the patient shares an opportunity through that report. But I can then take this and say to the principal investigator of the Focus 4 trial, Tim Morn in Oxford, you know, Tim, there are 20 patients in Wessex, and these are the doctors that look after them that might become eligible. Now, if it's the case that only 15,000 patients of the 365,000 or 400,000 incident cancers per year are entering trials, what if we could change that, chosen according to molecular stratification? Now, in the NHS, when it goes live, there will be targeted panels for patients. And gradually, as we improve the evidence base from this type of activity, it'll be possible with affordability to bring more whole genomes live for cancer. Now, because this data is difficult to deal with, it takes us between 10 and 35 hours to analyze a genome, more complex if there's more family members. But we built a coalition of researchers from 24 countries to work on the data. And now they've won over £24 million in grants, and they have access to this data, and they work themselves in organized domains according to different diseases or cross-cutting domains. For example, Munir and I are together in a stratified healthcare domain with pharmacogenomics. And they have access to this data. If I share with you that we hold 1.6 billion individual clinical data points on these people, and that's without primary care or prescribing data, this is becoming a rich way to chart the longitudinal life course of the patients. Now, if we link that data to the ability to recall those participants according to an opportunity they might benefit from, they can choose or not to take up the opportunity. We are beginning to use the data to make a living long-term difference to care in the NHS. And our participants strongly signal that's what they want us to do. Now, specifically in pharmacogenomics, with Ellie McDonough, who's done a lot of work on this for us with the NHS, and with Munir, we had a look at the first 6,000 genomes. And it turns out that about 85% of them have a known gene-drug interaction, which if they come together, will likely either be a cause of harm or might mean that the therapy doesn't work for that person. And I'm going to come back to the therapy's not working. Now, why is it 85%? Because Munir showed you over 90%. Munir is right. The reason that we can't show you 90% is the whole genomes can't read bits of the genome that are relevant well to pharmacogenomics, and we'll come back to that in a second. But here are the things you can find. So look, you can find in 13% had problems that would increase toxicity or reduce starting dose with phenytoin. So clopidogrel requires activation in your and my body. 30% of people possess variants that mean it won't be activated and therefore won't exert its antiplatelet activity. Warfarin, Munir dealt with this brilliantly, so I won't, but it's now clear we should be looking very carefully at warfarin. This is a drug used in transplant rejection, and 2% of a genotype that might mean that they need a higher dose and may be inadequately treated and therefore at risk of transplant rejection. And I mentioned DPYD and 5-fluorouracil earlier, and these are areas which are a work in progress. And one of the areas that we struggle with whole genomes is CYP2D6, which is obviously one of the variants that Munir was talking with. So what we're looking at now is how we can get higher fidelity read through those areas, develop analytics that allow us to read through those areas, or use alternative orthogonal technologies to sequence those areas. For example, HLA, the challenging bits of the genome that elude us or evade us today, so that we can bring a more comprehensive pharmacogenomic-based whole genome. So as Sue mentioned earlier, we will have panels in the NHS for the 6.7% of people who have adverse reactions, looking at a restricted number of drugs, which we'll pilot later this year. But we will also pilot, as part of that process, returning pharmacogenomic reports to participants who are enrolled for rare disease and cancer, so they can carry a record of what might cause harm. I want you to imagine, we could do this today, but I want you to imagine that the device you've probably all got in this room, 95% of the UK population have one of these. Whether they can use them or not is a different matter, but they have them. But imagine that there could be an app on this in which you could have your information. Now, one of the things you probably carry with you most regularly is this thing, to stay in touch with people. What if you could carry your own risk of harm and turn up as that person did in North Wales and say, don't give me any succinylcholine, please. So this is an empowerment moment. However, if we're going to do something like that, we have to do that with primary care, because we can't have a situation where people are unsighted in the health system on potential for harm. And a natural point to develop those type of things is with primary care. And I'm delighted that Imran and Nadeem are here to speak to you about this later. So this is how we're thinking about this. Everything has to be done with the impact on the NHS. So for those of you in the NHS, this is going to sound possibly a bit far-fetched. But remember, 5.5 years ago, so would have 100,000 genomes. But nonetheless, you have done it. So this is not beyond us. I'm going to finish with the future opportunity and lay it out and say this is not fully formed, and it's an opportunity for you to share your thoughts. We have been fortunate. I mean, I suppose probably all of you would agree, we don't like to look at pictures of our politicians that much these days. But actually, I am showing you this man because he, like the 2 prime ministers, 2 secretary of states, of which he's one, and 6 health ministers, they are solidly behind you and this area. They think this is a very important area to develop. And that prompted him to announce a range of things, that we would sequence 1 million whole genomes. So 500,000 is a Sue's reference to the National Health Service, and that's already funded. 500,000, which is also pretty much funded, is UK Biobank. And then there are 4 million other analyses, and we'll come to those in a moment. But it's hard to have imagined, if you thought back maybe 10 years or so, that somebody would stand up and say, our aspiration to sequence 5 million genomes. Now, I need to tell you today, 5 million genomes at whole genome level is unaffordable for a public system. I've got to be honest with you. So it's something between 0 and 5 million. I'll give you an idea of what that is. So if I mentioned this breakdown, so that they're already going to be done. And we'll be having all the amenities of the 100,000 genomes in this in terms of access, opportunity to have research linked to patient choice to have the test, and then in the NHS. Then there may be 1.5 million other genomic tests that are done from other sources, including NHS testing of other types. And then there's 2.5 million that might be whole genomes or other analyses, and that depends on how much money we can raise. Now, clearly, that is not a government-only problem. I have to get funding from other points. But we are looking at a number of areas that we can bring live. I'll put a bit of flesh on 1 or 2 of them in a moment. And we have also, to go back to the earlier question about industry, we've also had several direct interactions, not just with academic and NHS colleagues through workshops, but also with industry. And industry are indicating an interest to support and fund some elements of this program, especially the trials area. And in parallel, there is also 5 million early detection cohort, which is about understanding how AI wearables and multi-omics can be used to detect disease earlier. What if we could find cancer with cell-free DNA, intervene earlier and produce far better outcomes? If we have 365,000 incident cancers and 166,000 die, it tells you we need to do better. So I'll just show you very briefly that we need your input to look at sequencing strategic cohorts. We will also have a research program that we're proposing that looks at evaluating whole genome sequencing in the newborn instead of the Guthrie's test. But that is research. That is not direct healthcare. And there's no guarantee that that will necessarily ramify into healthcare. But the areas we are looking at, and we need value input, is we wish to extend the rare disease program, focused on the residual unmet need that there is in rare disease, and link this into trials, as I described earlier. So in other words, create the platform for the point I was describing earlier. We will focus in the next phase on cancer clinical trials, enhancing the opportunity for cancer patients to access new medicines. I mentioned newborn screening, but here is your opportunity in pharmacogenomics. And we can look also at how we apply innovative technologies, new other omic tests, other ways of sequencing. And this will be available to you on the website. But one of the things we're looking at is, can we apply whole genome sequencing along cancer trials and use that advanced molecular stratification to enhance the offering over a standard large panel that will be available in the NHS. So look at the way in which these genomes can be used to effect a better outcome for patients using stratification. And then in pharmacogenomics, we are actually working on establishing a way of doing pharmacogenomics in the National Health Service. What about pharmacogenomic screening? So what the workshops indicated was a number of areas where they thought this would be particularly important. One that came through very strongly is psychiatric medicines, where there is potential for harm, but there were also opportunities in cancer and in cardiovascular disease that were raised. And the final point, which is an intriguing point, what if you and I asked the question of every new medicine, bring us your new medicine, let's look at how much it costs, but why don't we develop together a notion of whether you put a whole genome alongside real-world experience of deployment of this medicine, you could understand who would benefit from it most. Now, that won't work for everything, but let's imagine that we took the most expensive therapies that exist, or ones where we have a suspicion that they don't work very often, and that we could use the genome to choose the right therapy for the right person. Then, what possibly can happen, don't know if it's for certain, but what could possibly happen is drugs that appear unaffordable today, because we are targeting the people who will most benefit, suddenly become affordable. A piece of work that has been done is around how whole genome growth will be around the world. And this was done by the Global Alliance for Genomic Health. And what it suggests, if you looked at this intercept here, is that by 2023, there will be over 60 million whole genomes. I think that's probably a bit optimistic, but there's plenty of size of activity in this. There are now 244,000 whole genomes in the TopMed program in the United States. So Sue showed this slide, but I want to draw out a different point for you. I want to suggest to you that a national genomic database with a concentrated genomic testing from the NHS, with the offer of research, with the offer of longitudinal life course follow-up, with the potential to recall patients to offer them opportunities they might not receive otherwise, and to be able to know who those people are so we can make sure we target those opportunities. De-identified for you and others to research on, including academia, the NHS and industry. It represents a fantastic opportunity for therapeutic innovation and for pharmacogenomics. And it's here in the United Kingdom. And though the United Kingdom is now the most advanced nation, it feels awkward to say those words, doesn't it, all advanced nation, but you are the most advanced nation in the application of genomics in direct healthcare now. But I believe that actually no one single nation can do this on their own, and the future's got to be a global coalition of intellects to solve these problems faster for patients so we don't delay in getting the maximum benefit. Genomics England is here to support the National Health Service and will continue to do so in making sure that we have the most advanced, transformed health service for the application of genomics in direct healthcare. I'd like to thank all the people in this program. I would have to show 100 slides if I thank them personally, so I hope you'll understand I bracket them together. But as you see me, so should you see them. I should thank our funders, without which we would never have done this. But I'm also going to thank the most important people in this program, and they're not me, and they're also probably not you unless you're a participant. They are these people who want you to see them, even though many of them have not yet received an answer. Because actually, for them, what's most important is that someone like you is continuing to take an interest and pursue the possibility for them that they might get an answer, or maybe a therapy, or maybe an opportunity to treat their cancer. And that's why they want you to see them, and that's why they're solidly behind us. And if you do want to get in touch, please do email us and let us know of your thoughts around what I've proposed to you. So your mission, should you decide to accept this, is to help me to shape the 5 million genome analysis. You are being consulted. Thank you.